very often, we are the ones that will pick up these things at the earliest stage, and we have the duty to break the news to the parents of affected children. And what we tell them and how we tell them is very important, and the initial support that they are given. And they do remember it, because I've come across many parents that I broke similar news to more than 30 years ago. And when I meet them, they remember exactly what I told them and how I told them. And many of them show gratitude. So it's very important that we take this meeting seriously. This is the third time, I believe, we are talking about neurodevelopmental disorders here. We've had Dr. Ayorinde, yes, who spoke about cerebral palsy last year.
Now.
You are here now.
Yeah, you know.
Okay. And we've also had Dr. Takon, who spoke to us about tics. And so it's not surprising that we have so much interest in this topic and it's coming up again. It means that there's something very important that we need to know more about. So I do not have to say much other than to welcome Professor Esegbe to this meeting. And of course, the moderator is the authority in this area, Professor Leshi. So I welcome you as well. I look forward to a very interesting meeting. I welcome also, I think I saw our president of PAN, Professor Ogunride. You are welcome. And also Professor Grange. Everyone is welcome. Without further ado, I'll hand over to Dr. Elitu to continue with the proceedings. Thank you all very much.
Thank you very much, sir. I would like to also hand over to Professor Leshi to moderate the session, and then the presentation can go on. Over to you, Professor Leshi.
So good afternoon, everyone. Let me once again appreciate Dr. Mobolaji Lawal and Dr. Letu for inviting me to moderate the session. The guest speaker is a distinguished professor of pediatric neurology who has worked extensively in the area of neurodevelopmental problems, as well as adolescents and cerebral palsy. So indeed, the choice of Professor Edwin Esegbe to give us this talk is an informed one, and I'm sure he will feed us and tell us the latest things, what we need to know at the level of primary care pediatricians on how to initiate the management of children with neurodevelopmental problems. So without much ado, I'd like to invite Dr. Professor Esegbe to share his slides, and then we will listen to his presentation and then take questions afterwards. I believe his presentation shouldn't last more than 30 minutes, and so we can take questions thereafter. Also want to acknowledge my teachers on the platform, Professor Grange, and I also see Professor Gala. So you're welcome, sir and ma. Over to you, Edwin, for the presentation. I think you should be unable to share the slide.
Okay, so you shared it now.
Okay.
Okay.
All right. So I think we'll just go on.
Please go ahead.
Once again, good afternoon, distinguished elders, senior colleagues, and participants. I want to thank the organizers for this wonderful opportunity given to me to share my thoughts about management guidelines for children with neurodevelopmental disorders. A lot of you know me as your student, so I don't think I need to introduce myself any further. So I'll be using this outline to talk about the topic. The objective will be to share information and knowledge about management guidelines for children with neurodevelopmental disorders. So what are neurodevelopmental disorders? The DSM-5 defines neurodevelopmental disorders as a group of conditions with onset in the developmental period. The disorders typically manifest early in development, often before the child enters grade school, and are characterized by developmental deficits that produce impairments of personal, social, academic, or occupational functioning. So on your screen, you see examples of neurodevelopmental disorders. I'll just mention a few of them: autism spectrum disorder, ADHD, attention deficit hyperactivity disorder, intellectual disorders, communication disorders, and of course, motor disorders. So the global prevalence of neurodevelopmental disorders ranges from 4.7% to 88.5%. That was following a systematic review sometime in 2019. Specific rates that were identified in that review showed that the motor disorders were prominent amongst the neurodevelopmental disorders. In Nigeria, Bakare et al. Reported a prevalence of 0.9% for neurodevelopmental delay among a cohort of under fives. They looked at those in the under five clinics. They were 0 to 3 years, and 0.9% of the children were found to have neurodevelopmental delay, which by implications means that they probably had neurodevelopmental disorders. Studies from neurology clinics in Nigeria indicate a predominance of neurodevelopmental disorders, with motor disorders ranking highest. Usually, these disorders do not occur in isolation. There's often an overlap within the neurodevelopmental disorders and with other disorders. They are beginning to become a problem, even in developing countries, because of our increasing population, which means per 1,000 or per 100,000, the real numbers will also increase. And survival of vulnerable children who ordinarily, before now, because of the lack of expertise of care, wouldn't have survived, and as who are not surviving, they are making the burden even much more. This is just the prevalence of child neurological disorders in Nigeria. Ejilogu Yiltok, that's in Jos, Iloje Zora in the eastern part of Nigeria, Lagunju, Okafo in the western part of Nigeria, Wamanda from the north, and Frank Briggs from the south. Just to give an idea, a spatial idea of what the neurodevelopmental, their incidence or their prevalence in our environment, is like. So these children with neurodevelopmental disorders, their healthcare needs are often multidisciplinary. They require diverse expertise in identification and management. That makes cost of management quite high. Often requires family and community participation. And all of this occurring in an environment where there are competing non-orthodox management modalities for these same conditions. These children are children with special healthcare needs whose management is fraught with challenges, especially in developing countries like ours. So there is a need, when one looks at all of these complexities, there is a need to have some sort of formal guideline, for the management of these patients so that we can optimize outcomes in them. From the national perspective, the National Child Health Policy, which is the instrument to provide long-term directions for protecting and promoting the health of children in Nigeria, classifies children with neurodevelopmental disorders under children with special needs. And currently, there is a program ongoing, the development of a program that will look into their management, their healthcare needs, and make that a policy. That is ongoing. So as it is right now, though we have a national policy on child health in Nigeria, but as it addresses children with special needs, that is still in the works. So generally, when we talk about guidelines, guidelines are expected to have the following characteristics. We should be able to project health outcomes. In other words, we should be able to say, okay, this is where we started from and this is where we are right now. We should be able to project costs and management of conditions using the guidelines. There should be a relationship between evidence and the guidelines. And of course, with empirical evidence over experts' judgment, there should be a thorough literature review so that all manifestations or all presentations of the disease conditions are managed. And then methods used to evaluate the scientific literature should be clearly spelled out. The strength of evidence should also be assessed, and the use of expert judgment should be considered. And then the strength of expert consensus should also be looked at. And then, of course, independent reviews and pre-testing. All these are properties, or those are characteristics of disease management guidelines. And these characteristics make disease management guidelines, a very complex process to build and requiring a lot of resources. So with regards to management guidelines, we should have an assessment, treatment component, a monitoring and evaluation component, as well as a prevention component. So looking at assessment methods generally, surveillance. Surveillance is a cumulative process that's aimed at identifying children who may have developmental problems and is performed at every well-child visit, is done for all children at every visit or contact with the health system. Now, it's a bit different from screening, which is the administration of a brief standard tool for the identification of children at risk of developmental disorder done at specific times using standardized tools. And then use of specific tests for the definitive assessment of a disorder when we are considering diagnostic evaluation. All these are assessment methods that are considered when one is looking at management guidelines for children with these disorders. The American Academy of Pediatrics recommends that for developmental surveillance and screening, that surveillance should be carried out at every visit, which means every visit of the child to a health facility. That child should be given the opportunity, surveillance, that child should be assessed. Then the use of standardized tools pegged at specific periods of child development at 9 months, 18 months, 24, 30 months, 3 years, 4 years, 5 years. So this is quite loaded, and to ensure that deviations from normal are identified early and other management modalities can be introduced. Child not reaching milestones can be measured on surveillance. Child has known high-risk medical conditions, or can be identified, such as also children with significant environmental stresses, as well as children with parental concerns about their development, about how about their growth. It's also important that these are considered when using the standardized tools. For us as an association, in the past 18 months,
It appears we have lost Professor Segbe again. I don't know.
Particularly in the past 1 year, there's been an aggressive drive to ensuring that the various societies within the association, come out with standardized management guidelines. That is still a work in progress, and hopefully of some management guidelines. So you bear with me when I organizations. Usually or commonly, areas where a child with a neurodevelopmental disorder is likely to visit and would and deviations from normal will be noticed, or being and deviations from normal will be noticed at the health facility, the home, and the school. So at the health facility, there should be routine surveillance for developmental disorders at specific periods of development. So the use of development.
Hello, Edwin. I don't know if you can hear me. You're breaking now, can barely hear you. Is it possible to use your phone whilst the IT person shares the slides for you? Professor Leshi, what do you think?
I think that might be. Sorry, Edwin, did you hear Sandele?
Very important. We have one that has just been validated.
Sorry, Edwin, Professor Segbe, we can barely hear you. If you can hear us, we can barely hear you. And there's a suggestion that maybe you want to connect with your phone while the secretariat shares your slide. Can you hear us? Sorry, Edwin, we cannot hear you. We cannot hear you again. So please connect with your phone while the secretariat shares your slides. The IT person will share the slides. Sorry, Edwin. Hello, Professor Segwe, can you hear us?
Okay, he's going to join with his phone now.
All right. Yeah.
All right. Thank you.
Professor Segbe, can you hear us?
I can hear you.
Okay, so we're suggesting that you continue with your phone while
Yes,
the IT person will share your slides. So please, IT, please go back to where.
Recording in progress. Meeting is being recorded.
Can you hear me now?
But it looks as if you have a second device. Switch that or mute that second device.
Done.
We can hear you loud and clear. All right.
Loud and clear.
Yeah,
Okay.
much better. So please,
Okay.
IT, kindly go back to where we started having problems. I think he was talking about assessment tools, assessment guidelines. No, we're past this. We're going past this. Go on.
Slide 14.
Go on, keep going.
Slide 14. Yes, so this is where we are.
Right.
Once again, my sincere apologies. So with regards to guidelines, the assessment guidelines, at visit for surveillance and screening, tools that should be used include the Ibadan Simplified Developmental Screening Chart that was developed by Lagunjo et al. In Ibadan, the Ages and Stages Questionnaire and BEANS.
That's the previous slide, please. IT, previous slide.
All right,
Edwin, please go ahead.
All right, so assessments can also be done in the homes. Observation of developmental red flags or delays, and this can take place all the time when parents notice that there is a developmental delay in their child or in any of their children. They also can participate in the assessment of their children. Then in schools, this can be achieved via implementation of the school health program, where we have school health services, where screening is part of school health services. And this can also be done every term. Currently, a lot of schools do it at the beginning of the year, but for the much lower age group, particularly those who are less than 3 years, this can be done every term. And the teachers, healthcare providers in the schools can carry out this screening assessment, particularly when they have been trained. The next slide. So looking at taking it a step further, particularly after surveillance and screening has taken place, at the health facilities, it's expected that diagnostic asset evaluation will take place. And this diagnostic evaluation includes the use of standardized tools and equipment, and using the expertise of those who have been trained to carry out this. The diagnostic evaluation can be in the form of genetic testing, use of diagnostic tools to evaluate these children other than the screening tools. And this can be done in health facilities after screening or after the outcome of screening. Sometimes all of this can take place within the same facility. But if screening or surveillance took place at a lower level of healthcare delivery, then there can be referral to the specialized health facility for this to take place. And the key person of these are the pediatric neurologist, the neurodevelopmental.
You're muted, Edwin. Please unmute yourself. We can't hear you. You're muted. Please unmute yourself.
I think the system, the healthcare system, and the social welfare system should think of supporting parents along this line. And they should do this at the notice of red flags and after they might have obtained any results of screening. Again, those key persons here are parents, caregivers, and siblings. And then in schools, early referral for diagnostic evaluation. Once in the school health program, it has been observed that the child has failed the screening test or has performed suboptimally in the school test, or the child is noticed to have poor academic performance that cannot just be explained by other obvious causes, that child, should be sent, for diagnostic evaluation. Now, talking about treatment, for treatment, basically, for children with neurodevelopmental disorders, treatment is a multidisciplinary thing. The reason is that when there is an abnormality in the brain, or that has to do with development of the brain that controls several activities, particularly in terms of cognition that involves intuition, knowledge, and social interaction, there is a need for multi-specialist approach. And so as a guideline for institution of care, children with neurodevelopmental disorders, it's important that we have a multidisciplinary approach. And then the use of adaptive and assistive mobility devices need to also be considered. These tools do not only help the children achieve the optimum, but it also helps with emotional and psychological development. I was at a recent workshop where we were talking about the use of adaptive and assistive mobility devices, and we had persons who had persons with disabilities. At the beginning of the workshop, everybody was asked about their experience about play, and interestingly, almost all those who were with disabilities said they never played. And so play was not a very good idea because of their disabilities. So treatment guidelines should include that. In the treatment of comorbidities, like I mentioned earlier, these neurodevelopmental disorders do not occur in isolation. It's either the process that brought them into being, it's also affecting other systems or other aspects of human development, or the limitations brought about by the disorder, impinging or affecting other aspects of human existence. Of course, treatment should also include institution of educational and rehabilitation services. Now, management guidelines of neurodevelopmental disorders in health facilities. It's important that we have them in health facilities. The reason is that they are a point of call for care provision. Disorders need medical intervention to optimize health outcomes. So people with neurodevelopmental disorders will always visit hospitals. And most of care that is provided there is more often evidence-based. So the likelihood of getting something productive out of care, is higher in health facilities. So they visit the place, they spend time there. It's important that these guidelines are in hospitals and in health facilities. And the resources needed there are skilled healthcare professionals, special healthcare facilities and equipment, and access to health insurance. Okay. So the management guidelines in healthcare facilities. Number one, our health facilities must be able to conduct developmental assessment of all children. The health facilities must be able to do that. It should be hospital policy that emanates from, I talked about policy development for children with special needs not too long ago. This is something that must be a policy that must be implemented at all levels of healthcare delivery. And the question now is, how do we develop capacity to be able to carry out developmental assessment? Now that is important. That is a total, that's another kettle of fish entirely. But every health facility should have facilities and capacity to assess the development of our children. We should also be able to carry out a thorough diagnostic evaluation if screening is suggestive of a neurodevelopmental disorder, particularly our tertiary health facilities. They should be equipped, they should be able to do this. There are instances where patients have to travel hundreds of kilometers to very few tertiary health facilities in this country, even when they have those tertiary health facilities in their state. This increases the cost of care provision and also encourages a default from care and even the guidelines that will be stated. The health facilities should also be able to coordinate an appropriate multidisciplinary assessment and treatment of neurodevelopmental disorders. So it's not just enough to be able to screen or make a diagnosis. These facilities should also have the capacity to coordinate services. Again, it depends on the availability of the specialists, the willingness of the system to employ as many persons that are required to be employed. And of course, we have this issue of the Japa syndrome now, where quite a lot of highly skilled personnel are jetting out of the country. But as part of management guidelines, our tertiary health facilities, especially our tertiary health facilities, should be able to do this. Our lower levels of healthcare delivery or provision, service provision, should be able to communicate and connect and have a well-developed referral system to ensure that these guidelines are in place. Our health facilities should also be able to facilitate appropriate evidence-based and structured educational and behavioral interventions for children. So children with neurodevelopmental disorders, they also require educational, emotional, psychological development. So again, it's not just provision or prescription of drugs for certain comorbidities that they might present with, but it's important that the health facility is able to coordinate this. Also coordinate long-term treatment planning and family support and the support of the child. Again, this is a major policy issue because there has to be structures on ground. They have to be budgeted for, and people need to be asked to be accountable for this. Most hospitals, in most settings, the pediatrician will have to go the extra mile. So most of the times with their own resources, in ensuring that their patients even receive or are engaged or have access to this type of long-term planning and follow-up. Again, I do know that for children with neurodevelopmental disorders, sometimes treatment and management is often interrupted because parents are not, or caregivers are not satisfied with the kind of progress their children or their wards are making. And so they go looking for alternative means. So by the time they come back, time has been lost. You have to start all over again. So long-term planning is influenced by a lot of factors. However, management guidelines in healthcare facilities must include this. And then to assess the use of alternative and complementary treatments and discuss their risk and potential benefits. We cannot shy away from some of these. Some of them are contentious, but whether we like it or not, we exist in a system where the average parent who has a child will want anything that can be done for their children. And some of them have come and they've heard all sorts of stories. They've seen proof. Some of the proof, even scientific, maybe not with strong empirical judgment. However, the health facilities must have the capacity to accommodate, look at this treatment, and be ready to discuss the pros and cons, with parents. Now, I will just use attention deficit hyperactivity disorder to just highlight one neurodevelopmental condition and how we can move from observing clinical features, to management, to long-term management. So the features of ADHD include hyperactive symptoms, impulsive symptoms, and symptoms of inattention, as shown on the screen. So whenever a child presents with any of these symptoms, fidgets with hands and legs and squirms when seated, runs and climbs when it's not appropriate, has trouble participating in group activities, when we notice or when parents notice some of these things, it's important that somebody says, okay, let us take it one step further. So the DSM-5 diagnosis of ADHD is when there's a persistent pattern of inattention and/or hyperactivity, impulsivity that interferes with functioning and development as characterized by either or both of the following. At least 6 of the 9 inattentive symptoms that were showed in the preceding slide, and at least 6 of 9 hyperactive or impulsive symptoms that were also displayed. Now, once these are there, the diagnosis of ADHD is made. Now, the treatment guideline at age at diagnosis, if the child presents at less than 4 years, the treatment modality is parent training in behavior management, group-based support, environmental modification. As much as possible, the use of pharmacotherapy is limited. If symptoms persist, it is advised that a second opinion is sought. For those aged between 4 to 6 years, in addition to the psychotherapy and behavioral therapy, methylphenidate, if the non-pharmacological therapy fails or severe to moderate dysfunction persists. So that drug, methylphenidate, is advisable. 6 to 12 years, a combination of pharmacotherapy, behavioral therapy, educational interventions, and individualized educational interventions are advised. Often, the healthcare specialist attending to this child or to these children will be able to provide advice based on facilities that are available. And for the child that is 12 years and above, pharmacotherapy with adolescent assent, behavioral therapy, and individualized therapy is advised. These are the doses for pharmacotherapy. Another condition is another common neurodevelopmental condition is ASD, autism spectrum disorder. Early identification red flags that, if noticed, should draw one's attention to the possibility of autism include: at 12 months, the child does not respond to name; at 14 months, does not point at objects to show interest; at 18 months, does not play. Generally,
IT.
Yeah, so generally, the child avoids eye contact, and we want to be alone, has trouble understanding other people's feelings or talking about their own feelings, has delayed speech and language skills, repeats words or phrases over and over, gives unrelated answers to questions, has obsessive interests. So, when this begins to manifest in the child, it's obvious that there is a problem, there's a need for further attention. The DSM-5 also defines autism, the autism spectrum disorder, in a child when that child is said to have deficits in 3 areas of social communication and interaction, and at least 2 of the 4 types of restrictive, repetitive behavior. Before 2013, it was the autism spectrum disorder, included 5 disease conditions: Rett syndrome, PDD-NOS, pervasive developmental disorder, not otherwise specified, the autistic disorder, and child disintegrative disorder. But after 2013, Rett syndrome and child disintegrative disorder were removed, and the other 3 was described as part of the same spectrum of the same condition, and that's why it is referred to now as autism spectrum disorder. So once 3 areas of social communication and interaction are affected, and at least 2 of the restrictive repetitive patterns of behavior, interests, or activities are identified, the child is said to have autism. There are other diagnostic tools that have been used in the past. We have screening tools, M-Child diagnostic tools like the ADOS. They are also there, but I have decided to restrict this to just talk about it so that we remain focused. Now, the NICE guidelines for ASD indicate that we ensure,
Edwin, you have 5 more minutes.
okay, that we ensure that all autistic children and young children, that they have access, to multidisciplinary healthcare. It's important, and that the core membership, a multidisciplinary group should be set up that manage ASD. Okay, let me just quickly pick on one. Yes, with ASD2, in the management of ASD, we have target symptoms that will benefit from medications. These target symptoms, when a child presents with hyperactivity, impulsivity, inattention, distractibility, or has acts of aggression, or has repetitive behavior that are really disturbing, affecting affecting productivity in the child. Okay, so management in home settings. Management in home settings. Okay, let me get
Next slide. Next slide. IT. Next slide. Yeah.
Just move on to the next slide. Just move on. Let's talk about guidelines in schools. Okay, so the school is also an important place where we should have guidelines for management of children with neurodevelopmental disorders, because inadvertently some of them are in schools. However, there should be a deliberate attempt in ensuring that all children, as part of their rights, have access to education. So in schools, the schools should be able to locate assessment of neurodevelopmental disorders in the school health services. They should be screened for, they should be looked out for. A conducive environment for play and learning amongst children with neurodevelopmental disorders should also be created. Information dissemination and knowledge dissemination in the school curriculum on neurodevelopmental disorders should be there. So whether you're talking about school health services, healthful environment, or school curriculum, the school should be an environment for learning. At home too, parents should be educated, giving information about conditions of their child, their capacity to provide basic care for their children should be looked at, and then should be supported. There should be institution of parental educational programs that enhance parent communication skills, provide psychoeducation and behavioral management strategies, and parents should be linked with caregivers and support groups and organizations. So periodically, the management guidelines should be reviewed, looking at clinical outcomes. So on an individual basis, clinics can look at what has happened to their patients over a period of time. Have they improved with what has been instituted? What is happening? What was set up in schools? So that is one way of looking at it. Then conduct of randomized control studies, where those who are managed under specific guidelines are compared with those who did not have those guidelines. And of course, independent reviews can also provide that. Prevention guidelines, typically, these neurodevelopmental disorders, some of them are as a result of genetic, they are genetic in origin. So screening can help with avoidance, look at those who are susceptible, look at what relationship can produce that, and then prospective parents can be counseled as to how or what they should do to prevent that. So early diagnosis and adequate treatment, it's also part of what should be standardized or what should be looked at. And then for tertiary prevention, reducing disability and overcoming handicap, particularly in our environment where children with neurodevelopmental disorders are often not properly cared for because of other competing health interests from other children and other socioeconomic issues. So in conclusion, generally, management guidelines are crucial to achieving optimal health and social outcomes, particularly with neurological disorders. Here are some resources. I've spoken with every president of all of these associations, the Nigerian Association of Clinical Psychologists. A lot of people do not have access to. This is the next slide. don't have access to some of these persons. The Speech Pathologists and Audiologists Association of Nigeria, they are ready. They are always available for this, even long distance online communications. They understand that they are not, their number cannot cover the whole of Nigeria, but this again, their willingness to share their contacts, with parents or caregivers of children or other doctors who manage children with healthcare, with these healthcare needs is quite telling. And then, of course, the Association of Child and Adolescent Psychiatrists, as well as Association of Play Therapists in Nigeria. So basically, in the past couple of minutes or thereabout, one has tried looking at management guidelines for children with neurodevelopmental disorders, looking at them from a general perspective and highlighting the fact that we are still working on developing ours, and what we have, those that have been put in place in other places that have been found to be workable following empirical studies and evidence. The need to also ensure that these guidelines are followed at homes and in schools, areas where the child is most likely to spend most of his time, and to understand that they are complex. The management of these conditions are complex and require a lot of resources, especially in an environment where expertise is lacking, the facilities to make diagnosis, technical diagnosis, they are also not readily available, and they have competing health interests, not just in the child, but in the socioeconomic status of the families. I want to thank all of you very much for your time. These are some of my references. Thank you very much.
Professor Segbe, for an excellent, well-delivered talk on the guidelines for managing neurodevelopmental problems generally, because it's relevant whichever part of the world you are operating from, but the emphasis is on Nigeria. So let's again appreciate Professor Edwin Esegbe, and I apologize too for the technological problems. I really apologize that we had to speed him up towards the end just to get through to the end. So we've had the presentation, and I think Edwin has beautifully highlighted the roles everyone has to play, whether you are in primary care, private, government organizations. And so the floor is now open. So we have a few minutes, I believe, for questions and answers. So kindly, you can also put your questions in the chat. So we have an option of putting questions in the chat. And the first hand I see up is Professor Adenike Grange. So kindly, Ma, unmute and ask your question. So might I suggest that we take all the questions and then Professor Sigbe will respond, unless Professor Grange's question is the only one. Over to you, ma'am. Please unmute. You're muted. Please unmute. IT, kindly unmute Professor Grange.
Can you hear me now?
Yes, we can, loud and clear.
Yes,
okay.
Yes, ma'am.
And you can actually also see me. Now, thank you very much, Professor Segbe. I'm always so interested in hearing about neurodiverse disorders, because not because I'm trying to be an expert in that area. Professor Grange and Professor Leshy knows that I'm not in that area at all. I'm in gastroenterology. But don't forget that gastroenterology is also linked to the CNS.
Yes.
So anyway,
yes,
I'm interested because of the fact that we have one in the family. And, you know, what actually bothers me, having noticed everything that happened with that person, was that he was behaving very normally as a baby, as a child, until the age of about 11. And then he started behaving negatively. And that, the kind of symptom that he had was, you can sort of say it was probably ADHD initially, because it was a little bit, a bit, you know, unattentive sometimes. But then you ascribe that to children being unattentive sometimes, you know. So what the problem is that if they are missed at that age, then they get to the teenage years where you really cannot even sort out what is the problem, you know, because they become very negative, they don't want to do anything, etc. I just want to find out from you, have you come across such situations? And, you know, if so, what can be done? The second thing that I want to say is that recently I'm hearing about neurodiverse disorders, not so much neurodevelopmental, but neurodiverse. What is the difference between them and neurodevelopmental? I want to hazard a guess that probably neurodevelopmental, you can actually pick out some gross problems, but in neurodiverse there are more subtle symptoms. But anyway, then we mustn't forget about stigma, the stigma that these children carry with them. Thank you very much. So just speak a little bit on those three.
So thank you very much, Professor Grange. You've raised three very important issues about ADHD developing in an older child, talking about neurodiverse versus neurodevelopmental problems, and then the issue of stigma, which is often clouds the management of children with neurodevelopmental disorders. Thank you very much. I think we'll just take any other questions. There are some comments in the chat. Dr. Tare Bew notes that a multidisciplinary approach is the hallmark to managing neurodevelopmental disorders. I can only agree with that. I'm sure Professor Sigbe will agree.
Yeah, yes.
There's a comment from, I believe, Dr. Ekore, a very diverse and up-to-date analysis of neurodevelopmental disorders. We appreciate you. That's just a comment. So over to you, Edwin, for a response to Professor Grange. I'm guessing I don't see any other hands up. But maybe let me just add my own questions, because one of them is actually related to Professor Grange and something you said about surveillance. And I know that in the UK, they have something called the Red Book, which is an extremely important surveillance tool that they use and rely upon to make those diagnoses very early. And I know there was a time, and this is where Professor Grange comes in, during the presidency of Dr. Mobalaji Lawal, there was an effort through Mrs. Saraki to develop a similar document, and I also believe that that was when Professor Grange was Minister of Health, to have this document developed by Mrs. Saraki and to be used widespread. And I think that would have been an excellent thing if it had taken off. Although I do know some private hospitals in Lagos have similar documents to the Red Book, not as detailed, which kind of captures a few of these developmental things. I think Premier, Lifeline have such books. So I think, I don't know how we can PAN, and I'm glad that the PAN president is on, how we can, if we can resuscitate that document as an important screening tool for everything regarding children in Nigeria. So those are just my comments. So if Edwin can just add that to the comments, and then maybe Professor Grange and Dr. Mobalaji Lawal can respond to the initiative that I had earlier mentioned, but I know it happened when he was president of PAN.
Yeah.
So go ahead, Professor Segbe. Please respond to Professor Grange's comments.
Thank you very much. And let me also let me use this opportunity to appreciate our distinguished elder and teacher for her service to humanity in general. Her presence, at this meeting is also encouraging. Just like we have others too on the platform, Professor Gala and Professor Ogurinde there. So thank you very much. Now, one of the unique things about, at least I have observed about those who have interest in neurology, is that you always find out that there's somebody, they always had somebody in the family who had some sort of disability. My nephew had spastic quadriplegia from cerebral palsy. So I understood the pain, particularly when my sister came and dropped the child with me. I think one of the challenges we have is that we do not see deviation from normal as part of life. So every child is born, every child child should cry, every child is fine, everything is all right. And so even when the signs are there, there will be denial, until they become so gross, and then people will begin to identify them and begin to say, oh, I first noticed this thing 3 years ago or 4 years ago. But that doesn't mean that we also do not have subtle presentations. The other issue too is that, so there is the issue of the sensitization of the people, concerning how the manifestations of children with neurodevelopmental disorders. That's one. Number two, a child could also be in a higher socioeconomic class. And because of that, will function at a level that will be passed for normal because of the child's environment and the social input into the child's activities. And so while the child will be regarded as all right in that kind of setting, as the child begins to face much more complex scenarios that require the brain, to do more, you now begin to identify with that. So those are some of the reasons why we have late presentations, because it's almost impossible. It's almost impossible. I'm not saying it's not there for those signs not to have been there much earlier, but we just, because we didn't have that kind of training. So I think the issue of the red book, we can call ours the green book, can help so that the day you call yourself a mother or a father, you begin to note that this is what happens with sitting, with crawling, with smiling, and so on and so forth. And then over time, even the developmental changes we observe, they've changed because of looking at secular trend, of events and the degree of stimulation that these children also receive in, in the early aspects of development. So yes, there are scenarios where it could be missed. It could be much more subtle. Again, they're all a function of what we know and how sophisticated our environment is, and the challenges the child, we have to face. There are several children. There are several children who would go to a particular school, and because they are functioning at a particular level, their intelligence quotient, talking about intellectual disability, now they're functioning at a particular level and they are not challenged. People will not observe that. But once they walk into a new environment that is quite challenging, so the need for this surveillance is to develop the capacity for surveillance is there. It can be really emotionally traumatizing and psychologically traumatizing. First and foremost, if you are somebody who has always been productive, you see yourself, you've not done anything wrong, So why are you being punished? What is going on? And so on and so forth. And in our environment where, until recently, where we started having it virtually in every community where these conditions were rare, somebody is always blamed, particularly the woman and all of that. So those are scenarios that make the child with neurodevelopmental disorder, a huge burden. And most of the times, I keep saying the women get missing in terms of productivity. They now need to sacrifice their whole life. I've been in a meeting where it was a meeting where we had children with neurodevelopmental disorders, and it was time to eat. And 2 or 3 mothers couldn't go there. They couldn't eat because their husbands were there, and they were like, "Is it food that brought you here?" Even though they were hungry. I mean, is it food that brought you? And so that is the level of denial, that parents, particularly the women, deny themselves. And then I will talk about neurodiversity shortly, but stigma. The painful thing about stigma is that stigma is not just enacted stigma, even self-stigma. I mean, the child who has, let's use disabilities, for example, a child who has polio now begins to think he is not good. It's not even his people, it's not even other persons thinking that he is not good. He himself does not think that, he can meet up the challenge. So the challenges of life. So enacted stigma and self-stigma are they're huge issues that we also need to sensitize, our people, about. But the good thing about it is that now, when you talk about children with disabilities, they are everywhere. So people can relate. They can relate with, what scenario, what situation is going on. But again, we need laws to protect the implementation of laws that will protect the rights of these children. It doesn't matter whether a child can do it and do it properly. The child should have access to it. Should have access to good conditions of living and so on and so forth. So,
Sorry, Edwin, I think you need to be very brief in your response because we have quite a number of comments in the chat, which I want to take.
Okay, so I will do that. So the neurodiverse. My understanding of neurodiverse, even though I've looked around it, is looking at manifestations or presentations that of cognitive, social, interactive interactions, that are peculiar, to certain conditions, but do not really qualify to be mentioned or described as those conditions. The issue is that the individuals, they perform within the normal limits of human function. At least they are not as characteristic or as typical, as they are as those who have the, if you may like, the full-blown disorder. There are those who also classify those who have autism, ADHD, as having some sort of neurodiversity. For example, autism, one of the spectrum disorders in autism used to be the pervasive developmental disorder, not otherwise specified, where all types of behavior was observed within them. But the issue now is there is not a standardized form of describing or classifying people as being neurodiverse. But the point is that each time they are mentioned, it just shows that there is some sort of special need or special presentation from the neurological perspective concerning this persons. I think others who have experience can also talk about their experiences. Thank you, ma'am.
All right, so thank you very much for the comments and for the response. We'll just take a few from the chat. So I've been going through the chat and I just, a couple of, there's one from Dr. Okobo, I believe is from the United States. Thank you very much for joining. our presentation. Now there's one from, and I think Dr. Okubo's point was about considering comorbidities, depression, anxiety, sleep disorders, and we should keep that in mind. I totally agree. I'm sure Edwin will have something to say about that. There's a comment from Elizabeth's iPad. I'm not sure who that is. I'm sure it's either most likely Dr. Nifabe, I suspect. My question, which member of the multidisciplinary team draws up the EHCP in Nigeria? At home, pottage is organized for the younger children. Do we have such services? And education and healthcare plan.
All right. So, okay. So I want to thank everyone. Thank you all for your comments. Right now, in fact, it's quite amazing how, I mean, if you walk into the ministries to find out, they have all these policies, all these programs, outlined. Meanwhile, those who provide the services have no clue or do not have contact with that. I think it's high time we begin to, maybe as part of our curriculum, begin to understand how the ministries and the agencies function. Our impact cannot just be limited to what we do in the hospitals. We need to know how, or find out how to interact with those who formulate, and probably we're also part of them, formulate and implement these policies from the federal level. Because if we do not do that, then we'll be having a lot of gaps. So you find the pediatrician, he's overwhelmed in his clinic. He's the doctor, he's the educationist, he's all of it. That's because we do not have existing structures to take care of these issues. Let me just use Toti's question to answer this. Is there any role for the school health program? Where function, as he puts in bracket, in early identification of neurodevelopmental? Of course, the school health program, and it's great that this current PAN administration, one of the major thrust of activities is the school health program. The school health services has screening as a component of it, but nobody is enforcing, nobody is ensuring that the school health program is implemented. You go to schools, even in schools where children pay millions of naira per year, their school health program is just a first aid box. One silver first aid box that is on the table of the headmaster. So there's a need for that policy implementation. Those who are responsible in the ministries of education and health, are supposed to look into this. What genetic investigations are available for children with developmental delay and learning difficulties? Well, right as it is right now, we do know that we have just private labs, and one or two institutional labs. Even those institutional labs are in private institutions that can run some of these genetic, analysis. But in our routine functional tertiary health facilities, we are still making communication. We are still trying to find out where this can be done. But we know that as part of our management, once we need genetic assay or genetic assessment, we call out to these persons. The Child Neurology Society of Nigeria, in the past 3-4 weeks, particularly with regards to this hue and cry about what we are doing, is now thinking of calling a stakeholders meeting. On the chat box there, I can see that the president of the Speech Pathologists and Audiologists Association in Nigeria is here. So we are all working at trying to see how we can have a national stakeholders meeting where all of these issues can be discussed, and we can come up with a policy document or a paper that we can now force the hand of government to ensure that is implemented, so that these things do not look strange, to us. So that's where we are. What roles or involvement for special needs educators in neurorehabilitation? They are very important. They have a specific role, and their role is such that if you're a specialist, you know that you cannot play the role of the other person. They need to learn with specialized setting, specialized equipment, and people who have been trained to do that should be given the opportunity to do that. Our system is not even fair to those who are regarded as average. Not to talk about those with special healthcare or educational needs. So yes, they have a role to play. And the doctor as the coordinator should be able to involve.
Sorry, please, those who are not speaking, please mute your mic. Please go on.
The doctor should be able to identify and then co-opt and then coordinate the activities of all of these persons who have a role to play in neurodevelopment of the child. So, thank you very much, Michael Okugbo. I can see you have added something there. Neurodiversity is a framework that has been proposed for looking at neurological conditions, that the human brain is sufficiently diverse, that what is considered abnormality may be that particular child's adaptation to his own brain anatomy and chemistry. Thank you for your contribution.
Thank you very much. We have actually exceeded the 15 minutes allotted for question and answer. It's quite exciting, engaging. I really want to appreciate the questions and also want to appreciate Dr. Professor Esigbe for his presentation. And of course, the roles of our seniors cannot be underestimated, that they're there for us. We appreciate. At this point, I want to hand over back to the conveners of the meeting, Dr. Eletu and Dr. Mobolaji Lawal, to continue. I think we've had a very good afternoon. Thank you.
Thank you, sir.
Thank you very much, Professor Leshi. Let me also join you in thanking Professor Esigbe for the wonderful job he has done. He was out of the country when I started harassing him about this presentation, and he came back not too long ago. I think last week or early this week, and he's been able to put up this wonderful presentation and show. So thank you very much, Edwin.
Thank you, sir.
As I always say, you'll hear from me again. And Professor Leshi, I said at the beginning of the presentation, I was waiting to hear your name when the list was being read out. So I'm still waiting. Don't worry.
I thought it was Dr. Mobolaji Lawal's name that you were talking about. Why my own name came?
So I'll hand over to Dr. Mobolaji Lawal for his closing remarks before we round up. Over to you, sir.
Yes. So thank you very much. Very briefly, because our time is fast spent. We have had a very good afternoon, and thanks to the lecturer, Professor Esigbe, for a very interesting lecture, very detailed, and ably moderated by Professor Leshi. All the important comments, the robust attendance. I see different experts here. I wish that we had more time. I would have liked to hear from them. There are so many. Dr. Bill is here, Dr. Takon, Professor Gala, so many people. PAN president is here. So we've had a very good meeting, and I want to thank everyone for your contribution. Sorry again about the technical hitch. And I want to commend our coordinator and Professor Leshi for innovation that enabled us to carry on with the meeting despite the hitches. Just a word about what Mrs. Saraki was doing. Yes, I do recollect that she started a personal child health record book, which had the child's records a little bit more than the usual growth chart and immunization record. It had all the personal records of the child, and the key thing about it is that the mothers were supposed to take those things home with them so that the records are not lost. But in order to upgrade this, if my memory serves me well, in order to upgrade this to something like the Red Book, there has to be accepted assessment, assessment of the development of the child. which will come as stages, which we will all have to agree on. And as you know, when first ladies start such programs, during their tenure, the program gains traction. At the moment they are no longer there, it sort of fizzles away. So the challenge for bodies like PAN, I can see here, is to seize those opportunities when they come, to take the initiative and build on it. We have all the experts in PAN who can develop this into a national document. And we don't have to call it the Red Book. We can call it, as Professor Esegbe said, we can call it Green Book or whatever color. But we have the capacity. And I want to throw that challenge to PAN as an outcome of this meeting. Perhaps if we consider it necessary, we have all the experts here, and it's not going to take us a long time to come up with a format. But it must incorporate the record of the child's developmental assessment in addition to the health records that Mrs. Saraki was trying to push. So once again, I thank you all for attending and for your comments, and I hope that the lectures will be shared, the slides will be shared later on. Thank you all and good afternoon.
Thank you very much, sir.
Thank you very much, sir. Thank you very much. I want to thank all the participants at this meeting today. We hope to see you last Thursday of next month. Promises to be an exciting session. And for those of us in the diaspora, I'll be contacting you because we need to hear from you as well. So I want to wish each and every one of us a wonderful evening. And thank you very much, and bye-bye.
Thank you, everyone. Good. Bye-bye.
Bye-bye.
Thank you very much all for your wonderful comments.